Hello friends, welcome to the part 4 of my lecture series on investigations and diagnosis. In this particular part, we are going to emphasize more on the ECG component, which is a very important tool to diagnosis of coronary artery disease, especially at the undergraduate program, which is an important tool. Apart from that, I am going to briefly just tell you about the cardiac markers, which are again used in the diagnosis of coronary artery disease. Let's see what are the components which we need to keep in mind when we are making a diagnosis of ECG for the coronary artery disease. If you look at this picture, you see that the first diagram, you find that the normal ECG, which is before any event has taken place. The second component of this picture, you will find that there is a first picture which shows a tall tented T wave, and subsequently there is a ST elevation, and the T is still up. This is minutes afterwards, as soon as the acute MI takes place. Followed by hours afterwards, this ST segment is still elevated, but the T is now inverted. And also hours afterward, in some cases, you may find that there is a Q wave. And then days afterwards, it could be a Q and the ST segment and gone down, and there is a T inversion. And weeks afterward, that means the phase of resolution, the T has become upright and the QS pattern is persisting, which is there throughout the life. And this is how you are going to make a diagnosis that at what stage of the acute MI you have intervening. The same thing if you look at the 4 phases which are normally described: hyperacute phase, in which you find that the tall tented T waves, which I already described to you. Then the fully evolved phase, when the acute MI has set in and ST elevation is still there, and resolution phase when the Q has already appeared and the T is still inverted, and stabilized phase when the necrosis have already taken place. So these are 4 phases which you need to remember when you are looking at the ECG as a diagnostic tool. I'll show you some examples of some of ECGs which is very important from the academic point of view, also on the diagnostic point of view for the undergraduate program. If you see at this ECG, you find that there is a ST elevation on the chest leads V1, V2, V3, V4, V5, V6, which is suggestive of a acute MI. And also there is a tall tented T waves, which you can appreciate. And there is some T inversion or ST depression in the reciprocal leads. So this is suggestive of an acute extensive MI. The next ECG is suggestive of inferior wall infarction, which is involving the right coronary artery. There is a ST elevation in 2-3 AVF, and there is a reciprocal depression in the chest leads, which is particularly V2, and this is suggestive of a right coronary artery involvement. And also there is a ST depression in 1 and AVL. I'm sorry for the picture, which is not very good, but let's see further. Some of the leads which you have to remember, that whether it is suggestive of anterior lead involvement or there is a anteroseptal involvement, what are the leads involved, extensive anterior posterior leads, or lateral wall infarction, or inferior wall, or right ventricular infarction. So these are some of the things which you need to remember, particularly anterior wall, which is involving V1 to V4, anteroseptal V1 to V3, extensive anterior V1 to V6, posterior wall V1, V2, 1 AVL V5, V6 is the anterolateral involvement, inferior wall, which is 2-3 AVF, and right ventricle, that is V4R and V5R. A few of these things you may need to remember. If you look at the ST segment, particularly out of these 3 pictures which are showing you, the one which is the third picture, which is showing the horizontal ST segment, which is more characteristic of an ischemia there, whereas the upsloping ST segment, which is a normal ST segment, and Louis strain shows the downsloping ST. Again, you look at the pictures and then try to assess yourself that am I dealing with an acute phase of MI, or it's a phase of resolution, or it is a phase of stabilization. If you see this picture particularly, there is anteroseptal MI and a deep QS pattern. Already it is fully evolved anteroseptal MI. And in this particular picture, it is of some duration. And there is a bundle branch block, which you need to keep in mind. And these are also secondary to the ST involvement of SA node with AV node, and which may produce a RBBB or a left bundle branch block, which are again there till the time the MI is being treated, and sometimes they disappear, sometimes they persist. Accordingly, you have to deal with these complications. Again, this particular ECG, you find that there is a ST elevation in V2, V3, V4, which is suggestive of a anteroseptal infarction, which is of some duration, and there is a reciprocal changes in 2-3 area. All the reciprocal changes are showing us that the prognosis is bad as compared to the STT changes in which the reciprocal changes do not occur. And this is again an acute MI. And if you look at the same thing in the inferior wall, and there are some reciprocal changes. Acute infralateral MI, and then there is an inferior wall MI. Again, these are some of the changes which are commonly seen in your clinical wards when you come across the patient and you see these ECGs, you come across this. This is again inferior wall MI, the 2-3 AVF, which you need to remember, and also the reciprocal changes. This is acute inferior wall again, which is suggestive of changes into the concerned lead, that is 2-3 AVF. Acute anterolateral MI, again ST elevation, you can see that these changes are slightly different from each other, but all these things are representing different stages in which these coronary arteries are being seen. If you look at this one particular acute MI, it's an extensive MI. Again, you find that the ST segment is going up, right? But it is coving upwards. So you can see that the changes are slightly different from each other, but still representing the same LAD or LCX or right coronary involvement. This is again a 2-3 AVF, and these ECGs are important from the assessment point of view, and sometimes in the exams you get all the ECGs into. This is another ECG strip which is showing you some flutter waves. You can appreciate these flutter waves, and there is a changing RR interval which is suggestive of a atrial fibrillation with flutter. It is not possible to tell that whether this is secondary to a hyperthyroid function or it is secondary to coronary artery disease, but they are one of the complications which you need to diagnose and then try to do assessment with the underlying other investigations. If you look at this particular ECG, you find that there is a QRS which is widened, quite widening of the QRS. There is a notch on the ascending limb of the QRS, and you find that there is a T inversion. So there is a RSR pattern in one AVL and V4, V5, V6. That is suggestive of a left bundle branch block. One thing to remember in this particular situation is that all the left bundle branch block which are a newly occurred LBBB should be considered as acute MI and treated like that. Many times acute MI is masked by LBBB, and therefore we need to look back into the retrospectively the old ECGs and then see that whether this is a fresh left bundle branch block and then treat accordingly. These are some of the ectopics, again secondary to coronary artery disease, and this is again life-threatening situation. Please make sure that you don't miss this. And this is a ventricular tachycardia, and this need to be taken care of in a urgent manner, right? Like DC shock, or you have to act fast into this. And this is again worst condition, that is the ventricular fibrillation, which is again occurring in situations which need a urgent intervention. Biochemical markers which are commonly used, there are different types. Creatinine kinase or MB fraction, which is commonly used here, and cardiac troponin is another which is highly sensitive and highly specific, up to 98%. So these are the enzymes which are used. Earlier days we were also using myoglobin, which is myoglobin used for rapid diagnosis of acute coronary syndrome, as levels become elevated very early in the time course of an acute MI. And nowadays we are only focusing on this. Myoglobin is not used too much, but CKMB and troponin are the one which are commonly used. And this is showing you the total span, how the enzymes reach their peak and then are descending down. So this is all about this. And then also look at the algorithm for acute coronary syndrome. Patient coming to you with a chest pain, you find a ST elevation or no ST elevation. Do cardiac markers. If cardiac markers positive, then you treat acute MI or a STEMI or a non-STEMI. If the cardiac markers are negative, then you treat either unstable angina or repeat the cardiac markers like troponin and do some other investigations to further evaluate this particular. And that's how this algorithm goes for the diagnosis of coronary artery disease. This is all about this component, and I see you in the next component. Thank you very much.